Hi, everyone. The second component of the Health Inequity under COVID-19 module is to talk about pandemic patterns of health inequity. So what we're going to do is we're going to take what we've learned about gender and race and ethnicity and socioeconomic status and look at what's happening during the pandemic across those three different social identity components. And so we're going to start here. There's a lot of work being done right now, and this story came out in the New York Times and has a lot of really good data. What's really captured a lot of public attention is who is most likely to die from the coronavirus. And we know that people who are older are more likely to experience mortality from coronavirus. However, what we don't know is how is that distributed in the rest of the population? And there are a lot of people who are trying to figure that out right now. So let's start with gender. So what's happening during the pandemic? And what we know is the data from a whole bunch of different contexts, from Wuhan in China to Italy to New York to Texas. What we're seeing is that men are more likely to die than women from COVID-19, and they're more likely to have more severe symptoms as well. And so why is that the case? So the first instance, we can think about sex differences. So sex as opposed to gender, things that are related to the biology of being female or the biology of being male. And what we know is that genes and hormones and immune system strength all differ between men and women. Women have 2 X chromosomes, men only have 1. Our hormone production and its relationship in endocrine function and stress management, those are very different. And we also know that women tend to have stronger immune systems than men. And so all of these things are biologically based and are potentially going to have an effect on disease trajectories. However, there are also gender-specific differences, and 2 of the differences that have been identified early on in the pandemic are socialized differences in smoking rates, and we know that smoking puts people at greater risk of severe symptoms and death from COVID-19. And we also know that there are gender differences in people's willingness to seek care. So the idea here is it's related to that toxic masculinity that we talked about before, where men might be less likely to go to the doctor. They might be more likely to minimize any symptoms they might be having as just a minor cold or, it might be COVID, but I don't need care for that. And so they might be less likely to go to a physician or to a hospital, and they might be less likely to do that early on in their disease trajectory. And we know that the longer that you wait to seek care for COVID, the worse your outcomes are. So we have both sex differences and gender differences. So that's the general understanding of what's happening with gender in relation to the pandemic. Next, let's turn to race. And here what we know is, we're learning that people who are members of conventionally disadvantaged groups are much more likely to die than others. And we're not talking about absolute numbers here. We're talking about the rate of death, right? And so what we know, for example, this figure shows each of those bars represents a different group in the United States, a different ethnic group in the United States. And that bar is the rate of deaths per 100,000 people. So it's not the absolute number of deaths, it's the rate of deaths. And what we know is that African Americans are dying at a much higher rate than any other group in the United States, and definitely much higher than people who are white. And so that's one thing that we know. We also know that people who have indigenous ancestry are also more likely to die at not as high a rate as African Americans, but still at a very, very much higher rate than other groups in the United States. And so this is not just U.S. information. in the UK, what has been found is that Black people are 4 times more likely to die from COVID-19, and they have looked at differences in health, like pre-existing health conditions, and economic differences. You know, a lot of the first physician deaths in the UK were of physicians who were people of color. And so this is consistent across contexts. We know that for people in Indigenous communities, COVID-19 can be the worst of both worlds at the same time. And what's meant by that is that tribal economies in the United States are very reliant on things that have been shut down, so things like tourism or casino revenue, or a lot of development projects that have been suspended, and that they are also at heightened risk. And this has been traced in many contexts to a high proportion of households that don't have running water. So people who can't wash their hands in accordance with public health guidance around the pandemic. And we also know that Indigenous populations are often being left behind in the COVID-19 response. They're often being overlooked in terms of what's needed, in terms of getting resources to them. And so it's not just that they're being hit the hardest, they're also being overlooked in the response. And so there's some additional reading there for everyone if you are curious to read more about that. So what's behind the racial disparity? There's been a growing number of people who are really focused on figuring out why. What's going on here? And it's really important that we don't fall into conventional explanations here, because we really need to focus on what the data tell us. So, I think the first thing is that we cannot assume the problem is biological, that there is something that is different about the genetic composition or the immune response of people of color. There isn't any data to support that. What might be true, for example, is that people, because of ongoing racial inequality and discrimination and institutional racism, that there are, for example, pre-existing health conditions that are not equally distributed. But that doesn't mean it is something about being Black or being Indigenous that makes someone more vulnerable to the pandemic. Caution number 2 is that we really can't attribute the health impacts to misbehavior. The idea that people who are African American are taking more risks or not socially distancing or whatever it is. What that does is contribute to a racist pathology that isn't borne out in the population and isn't borne out in the data. And really, what it does is it makes it more likely for people to say, oh, this is a Chinese disease or this is a Black disease. And that is not the case. COVID-19 is affecting everyone, and it's really incumbent on all of us not to engage in propagating narratives that reproduce this racist pathology. Caution number 3 is that we need context, and we need that context to avoid impressions that certain social problems are primarily racial in nature. This produces the same problem as caution number 2. It introduces a racist pathology that some of those social problems have to do with race, as opposed to long-standing inequalities or inequity in resource distribution, or the likelihood that racialized populations might be more likely to be in roles where they're required to continue to go to work. And we'll talk more about that in a bit. So the real focus is that we don't know yet. We know that people are dying at greater rates. We don't necessarily know why. And we need data to identify why that's happening. But that's also really problematic, because while we have some data on the racialized distribution of morbidity and mortality for COVID-19, a lot of states are not collecting race data on COVID-19 cases, for example. And so there's a lot of places where a lot of the cases that are being reported are not also reporting racial information, and so we don't have that information. And that is also the case for a lot of information about death and COVID-19. And so there are a lot of places that are just not collecting this data at all. And if we think that we're doing better in Canada, it's unfortunate, but I'm here to tell you that we are not. Canada is also not collecting race-based COVID-19 data, and that is said to be hurting Black Canadians in terms of how we organize the response. Think back to the difference between an equality-based response, where everyone's given the same tool, and an equity-based response, where people are given tools that are more customized or appropriate to need. And if we don't know what need is, it's not possible to respond in the same way. And so there are some emerging efforts that are trying to really collect that data and make it widely available. So you can actually download the data from this website, where they are collecting whatever data is available on racial differences in COVID-19 morbidity and mortality. So there are efforts being made, and for example, the city of Toronto just decided that they were going to collect racial information on people related to COVID, even though that isn't mandated nationally in Canada at this point. Okay, so that's what's going on in terms of race and COVID-19. Let's now turn to socioeconomic status and figure out what's happening there during the pandemic. And way back in March, there was this piece that came out in The Atlantic that talked about the coronavirus being catastrophic for the poor. And essentially what we know is that people who are of lower socioeconomic status have less secure jobs, are more likely to lose their jobs, and are going to have fewer resources to be able to prevent infection and also to be able to deal with infection when it happens. And so in Canada, for example, this is a map that shows Montreal, and it shows the neighborhoods that are lower income. So the pinker the neighborhood, the lower income the neighborhood. And the size of those gray circles represents the magnitude of the pandemic in those places. And so gray dots, the bigger the gray dot means the bigger the outbreak, and the pinker the space means the poorer the neighborhood. And you can see that there is definitely a relationship between those things there. In BC, one of the things that we know is that people who became unemployed because of COVID are more likely to be in, for example, the service sector, in retail and trades, in construction, in arts, in other services. These are jobs that have lower median income rates to begin with. And so what we can see is there's been a real change in the unemployment rate for people in different age groups. And women between 15 and 24, their unemployment rate has skyrocketed under COVID since February. So what we know is that COVID is greatly affecting communities that are at greater disadvantage, and that the response to COVID, where a lot of people have lost their jobs, is also disproportionately affecting lower income individuals. I'd like to take a little while to talk about social distancing and the privilege of social distancing, and this relates to one of the readings that you were assigned for this week. And the idea here is that people who are less advantaged are less able to social distance, which might make them at increased likelihood of being exposed to COVID, of being infected with SARS-CoV-2, the virus that causes COVID-19, and of dying from COVID. And a quote from this article really hammers home the idea here. It says, "To the precariously employed, staying home from work for health reasons is a decadent luxury, one that they don't usually employ even outside the context of a pandemic." So even independently of a pandemic, people who are precariously employed do not have the same ability to tend to their health. And so we're going to take an example that was generated in the New York Times that looked at the mobility of people and the degree to which people restricted their mobility as the coronavirus spread. And this is just the line for San Francisco. And basically, the line across the middle is people moving the same as they usually do. If you go below that line, that means you're moving less than usual. And if you go above that line, you're moving around more than usual. And they used cell phone tracking data in order to create these graphs. And what we see is that the wealthiest people, so those in the top 10% of income, have limited their movement more than those in the bottom 10% of the same metro areas, according to the location data analysis that they conducted. And so what we can see here is the orange is the bottom 10% and the blue is the top 10%. And we can see that the degree to which people were restricting their movements is related to whether they were in the bottom or the top 10%. And so by the middle of March, when the lockdown really started to escalate, we know that people in the highest income locations had already cut their movement by nearly half. Poorer areas didn't see a similar drop until 3 days later, and we know that that distance between those 3 days could have been responsible for a significant number of infections within people who weren't restricting their movements. And so the article says, the data offers real-time evidence of a divide laid bare by the coronavirus pandemic, one in which wealthier people not only have more job security and benefits, but also may be better able to avoid becoming sick. The outbreak is so new that the relationship between socioeconomic status and infection rates cannot be determined yet, but other data, including recent statistics released by public health officials in New York City, suggest that the coronavirus is hitting low-income neighborhoods the hardest. And so there have been, while we don't have socioeconomic status data that is analyzable at a population level yet, and that the data sources are going to be limited because it requires people to track that, there's a group in London who has modeled the impact of 3 preventive measures according to an individual's class. And those 3 preventive measures are hand washing, working from home, and having access to a hospital. So, in the first instance, what we know is that the percentage of households with soap and water differs by class, right? And we also know that the percent of occupations that are amenable to working from home also differs by class. And so what you can see there is the socioeconomic gradient that we talked about in the last presentation, that at every lower level of income, there's an increasing level of disadvantage. So this is a perfect illustration of what that gradient looks like. We also know that in terms of people's distance to the nearest hospital, that people who are the wealthiest, for whatever reason, it could be a higher number of hospitals, it could be the location of those hospitals, have higher access to those hospitals. So they have less distance to go if they actually need a hospital. And so when you combine looking at hand washing, looking at working from home, and looking at getting access to a hospital, we know that there are gradients in all of those, and the impact in terms of the percent increase in risk of death relative to the wealthiest group, so they compared everyone to the wealthiest group, follows essentially a perfect gradient. And so we expect, based on this, that the likelihood of dying from COVID is going to follow a socioeconomic gradient from the wealthiest to the poorest. Another thing to think about that I really encourage you to pay attention to is the degree to which those gradients in health are patterned together. They're intersectionally patterned. So the idea is that race and socioeconomic status are patterned, disadvantages concentrated on both dimensions in terms of disadvantage. So lower socioeconomic status individuals tend to also be racialized individuals. And what these graphs show are the relative prevalence, so how common it is in the population to have a range of different health condition by census tract when you take the median household income of that census tract and by the median number of individuals who are racialized in that census tract. And so the idea here is that if you're higher up on the y-axis, then you are more racialized, and if you're higher up on the y-axis, then you have a higher median income. And so what we see is highly racialized neighbors have lower median income and vice versa across all of these different health conditions, and all of these health conditions have been identified as putting people at higher risk of increased negative outcome because of COVID-19. So higher likelihood of infection and higher likelihood of death, or higher likelihood of severe symptoms and higher likelihood of death. And so, because there are these pre-existing conditions that are known to predispose people of risk of severe COVID symptoms and death, and because the patterning of these conditions in the population by geographic location and race shows a concentration in racialized and lower income communities, again, we are predicting that we are going to see much more significant and much more adverse negative outcomes among those populations. Here in Canada, there's also increasing attention to what's happening inside institutions. And, in British Columbia, much of the pandemic has played out inside care facilities, inside prisons, inside institutions. And in Canada, COVID-19 is revealing incredible inequality that we have here when it comes to socioeconomic status and when it comes to people's situations when they are in institutions. And it shows the discrimination related to race, class, gender, and ability when we look at who is most impacted, who is most vulnerable, and who is dying at the fastest rate. And so while a lot of data that are available right now are American data, in Canada we are certainly not immune from the same patterning. I think it's also really important to mention that we're dealing with significant challenges in the global south. And the pandemic started in the global north it started in Wuhan, but it migrated quickly to Europe and North America. And as it makes its way to and through the global south, we are anticipating, given resource differentials and lack of infrastructure, very significant and adverse consequences. And so that is something to pay attention to. And as I'm sure people are aware, Brazil now has the second highest number of deaths globally from COVID after the United States, and we anticipate this to get worse in other areas over time. And so, to summarize the section on health inequity during the pandemic and the patterns that we're seeing, COVID-19 is disproportionately affecting men, people of color, and poorer individuals in terms of rates of infection, severity of symptoms, and the likelihood of death. The risk of SARS-CoV-2, the virus that causes COVID-19, follows a socioeconomic gradient that is often racialized, and that is that modeling that we were seeing and the data that we're also seeing about things that predispose people to risk of infection and adverse outcomes. We know that there are considerable data gaps in terms of tracking the racial, ethnic, and socioeconomic burden of disease at this time, and that expert predictions anticipate a considerably higher burden of disease and economic impact among disadvantaged populations and countries in the global south. And we'll leave it there for this portion of the module.